morning, everyone in the back row. Please raise your hand, indicate that you're here and you can hear me. Okay, just checking. If I can have the panel come up to the stage. This is the only reason they asked me to do this, just so you know. Good morning. That, and I can talk really, really fast. So I'm Clifford Mitchell, Assistant Director for Environmental Health and Food Protection at the Maryland Department of Health and Mental Hygiene. So I am going to introduce your first panel really, really quickly. Their bios are in your packet, so you don't actually need to listen to anything I'm going to say from here until they start talking. But you should know a little bit about them because it's an incredibly distinguished panel. Let me just take a minute to tell you a little bit about them. Dr. Thomas LaVeist, who will start, is the William C. and Nancy F. Richardson Professor in Health Policy and Director at the Hopkins Center for Health Disparities Solutions at the Johns Hopkins Bloomberg School of Public Health. He has studied major gaps in healthcare in America, and his work is actually leading to a new understanding of what will be healthcare needs for a minority-majority population in the United States in the years to come. The center conducts research with the goals of advancing knowledge on the causes of health and healthcare disparities and developing interventions to eliminate them. And his latest book, which I do not believe is on sale in the lobby, but is on Amazon. Yes, it's on Amazon. Is an introduction to health disparities in the United States and was released in 2005. And I'm not going to ask him what number it is on Amazon, even though I'm sure he could tell me. She will go next in the lineup, and then she will be followed by Dr. Stephen Teach, who serves as both the Chief of Allergy and Immunology and as the Associate Chief of Emergency Medicine at Children's National Medical Center in Washington, D.C. He also serves as the Associate Director of the Center for Clinical and Community Research at Children's National and is a Professor of Pediatrics and Emergency Medicine at the George Washington University School of Medicine and Health Sciences. His primary academic focus is patient-centered clinical and translational research on the disparities evident in the care of inner-city children with asthma, including their over-reliance on urban emergency departments for episodic care. Now, what I'm going to do is let them regulate themselves to some extent with respect to time. We're a little behind time, and I know that we're on a tight timetable this morning, so we will get little visual prompts. They have all been briefed that they're going to get little visual prompts, and if need be, we will allow time, if possible, for questions at the end, but only if time allows. So with that, I'll turn it over to Dr. LaVeist. Thank you for joining us, Dr. LaVeist.
So I've just been told that my PowerPoint presentation is in the newer format and they can't read it on this machine. So we're going to have to go without the technology. First, I want to just comment on that introduction, that speed talking demonstration we just saw. I'm a native New Yorker, so a native speed talker, and I just want to say that was really impressive. Listen, it was like those pharmaceutical commercials. We have someone here from Merck, right? Look, all those commercials. So I know, Dr. Mitchell, you're in your second career now with the health department. After having been at Hopkins for some time, maybe there's a third career for you as a speed talker with radio commercials for pharmaceuticals. So, I guess, I'm probably the only person here that's going to be speaking today whose professional career is not revolved around asthma. Can you not hear me? I have a lavalier microphone. I have never not been heard before. I can't believe that. Okay, can you hear me now? Okay, all right. Yeah, since I don't have PowerPoint, you have to at least let me be a moving target, right? I mean, I can't. But what I wanted to do is kind of talk a little bit about the work that we do at the Hopkins Center for Health Disparities Solutions, which is focused on the issue of health disparities broadly, not any particular condition. Am I doing this? Oh. Okay, how about if I just stand right here? While in my professional career I haven't focused on asthma, I'm a parent of a child who has lived with asthma. So I have some experience and some knowledge about the condition from that perspective, and I think that's an important perspective to bring in. I was so glad to hear a parent here to talk about her experience, an experience that I know so well and understand. But I want to talk about the work that we do and how some of the work that we do, I think, relates to this topic, because it's the issue of barriers to access to care and barriers to effective patienthood. And what I mean by that is that a patient who is effectively able to advocate for themselves and ensure that they get the appropriate care. And this is a huge problem we have that contributes to disparities. If we can accept that disparities in health outcomes are produced by a combination of factors, the environment that we live in, the communities that we live in, the exposures to health risk, as well as the exposures or lack of exposures to resources that are necessary to live a healthful life. Also, we have disparities in patient knowledge, behavior, preventive behavior, as well as illness behavior, impacting especially a condition like asthma, where so much of what you have to do is really self-care, things that happen outside of the healthcare system that are not. But also, we do have disparities that emanate from within the healthcare system. And I just want to talk about a couple of cases of healthcare organizations throughout the country, hospitals that we've studied, that we've worked with, and things that have happened and that I think it has some bearing. Were you able to get it up? Okay, I'll just keep going. So I'm sure most of you here are familiar. Most of you are familiar with the case of Diamante Driver. This was the 12-year-old boy who died in 2007 of a toothache. Now, if you're a health professional in the state of Maryland, I'm sure this resonated with you and stuck with you and probably will stick with you for the rest of your life, as it will with me. This is a child who died of a toothache because of a, for lack of a better term, comedy of errors and circumstances that came together to produce this outcome. He came from a low-income family. He had, his family was reliant on Medicaid. It was difficult to find access to dental services in the community where he lived. We all know what reimbursement rates are in this country, especially for the public programs. So we know that there are financial disincentives to practice in certain communities. Therefore, we have pockets within this state where there's inadequate health care. We're talking about moving to medical home models, but I can assure you that once we get there, that there will be medical home deserts in places where there simply will not be the available resources. And it's because health policy, the way we've organized the healthcare system in this country, we've organized it in a way that it produces disincentives to see certain populations. The Diamante Driver's family was one of those populations for which we have a disincentive to serve. Now, his parents did finally take him in to get care, not as quickly as we would have wanted to. So some of the contribution to his death, I think, falls on the side of the family and their inability to act quickly enough. So I asked you a question: what is the fundamental cause of death in this case? Was the cause of death abscess of an infection that spread to the brain, which is primarily biological related, or physiological definitions? Was the problem neglectful parents who didn't adequately respond to symptoms and get care? Or was the fundamental cause of death in this case health policies that create disincentives to see patients like Diamante Driver? And the answer is that it's complex. It's complicated. It's a combination of factors here. It's not simply an issue of access to health care. It's not simply an issue of patients not being effective patients and not getting care. It's not simply an issue of patients not wanting to get care or not showing up for care or being stressful health care. It's a combination of complicated factors, most of which happen outside of the care process and are not within the purview of clinicians, policymakers,
variety of factors that affect what we do. And this complication, I think, is particularly relevant all right. It's best we can be. So when we talk about disparities, how about if I just stand in front? Is better? Yeah. When we talk about disparities, we often talk about disparities emanating from this idea that it's, we talk about disparities, we often are talking about racial and ethnic disparities, which this is, of course, a particular problem that we have in this country. But disparities exist across a variety of characteristics and for a variety of reasons. There's a movement in this state to mandate cultural competence and training for clinicians. This is a policy that's been passed in other states and is really a way to see across the country. And one of the, I think, the important factors that we have to consider when we do this, and we should, and I think that we should do this, and I think that we should have this mandatory training. But one of the factors that we need to consider is that culture exists across many different dimensions, going beyond just race and ethnicity. That just because a person may be of the same racial ethnic group, a clinician of the same racial ethnic group, it doesn't mean that that person is automatically any better able to provide care to that patient. Because we all belong to many different cultures, and our ethnic and racial culture is just one. Let me give you an example. So one day I was at the airport in Birmingham, Alabama. It was at night. I got on the plane. I told you previously that I'm from New York, right? So I am literally a Yankee from New York. Literally a New York Yankee fan, right? Very popular here in Baltimore.